Wonderful. Thank you so much for that introduction. It's really nice to be able to be here with you and speak about opioid prescribing and pain management after EVAR and CEA. All right. So today we'll cover three main topics. We're going to review a little bit of opioid prescribing data from relevant to BMC2 from over the last couple of years. It's data that's been very kindly provided by BMC2. We do a lot of collaboration, and I'll speak about that in just a moment. We'll look at the 2022 goal and make sure we have some clarity on that, and then talk about options for teaching patients how to recover from surgery and how to help raise perhaps the bar for the groups that you're working with to help meet this new goal that we have. So first, a little bit about our team. As you mentioned, the Opioid Prescribing Engagement Network really is led by kind of a consortium of both surgeons and individuals like myself who are have training in anesthesiology and pain medicine. You might have met in the past Dr. Brummett, Dr. Inglesby, or Dr. Walji, with Dr. Inglesby and Dr. Walji being our two surgeons and Dr. Brummett being an anesthesiologist. And then our program director, Beth Cease. It truly is a team effort and a lot of individuals behind this group helping support the work that we're talking about. While we're talking about prescribing recommendations today, just know that our organization has a number of different avenues that we try to promote better opioid prescribing, better pain management, better care for patients after they're discharged from surgery. And that can involve a number of settings that are out there. And we're not necessarily going to go through all of them, but a lot of different avenues that we certainly help with in prescribing recommendations, and helping patients understand their pain after surgery is one of those key areas. So just to take a moment, I thought it'd be helpful to review some of the data from BMC2. You know, it's really a wonderful opportunity that we're turning our attention to this. You probably have a good understanding with BMC2 being essentially the first of several quality collaboratives with Blue Cross and Blue Shield, you know, looking at the prescribing goals and targets that have been met over the last few years here. So just a quick note before we dive into the years and the different data that goes with them. Note that most of these are applying really only to the opioid naive patients. So in essence, if a patient has not been taking an opioid within 30 days of hospital admission, those are the patients that these goals and targets apply to. I think we certainly recognize that individuals who have opioid exposures that are more recent, within the 30 days prior to their procedures, are going to have perhaps different pain needs, and thus wouldn't be appropriate for these goals or targets to apply to them. 2018, in terms of looking at the goals for both EVAR and asymptomatic CEA, the threshold there was to prescribe 10 opioid pills at discharge or less for those groups. And then in 2019, essentially adding on a bit here where the target is raised to have 70% of cases with that being the goal. Looks like similar prescribing goals and targets for 2020, and then in 2021, trying to get it to at least 80% of cases there. We can look at some data in terms of how well individuals have done, which we'll do in just a moment, but know that looking forward to 2022 and beyond, because of some of this good work, the goal has changed for opioid prescribing to decrease from this 10-pill threshold that we've been using over the past few years to a 4-pill threshold at discharge for both the elective EVARs and the elective asymptomatic CEA cases. And so we'll cover both that goal, where the rationale for that came from, as well as some thoughts on teaching patients to recover when they have these procedures with 4 or less opioid pills. So this is some of the prescribing data that we were talking about from BMC2 for the opioid naive patients. And on the left-hand side, you'll see the elective EVAR cases, and on the right side, the CEA cases. And the rows show you the different years for which the data is provided here. And they're broken up into 2 columns for each of the procedures, in which we show the percentage of all patients who've been prescribed less than or equal to 10 opioid pills at discharge, and then the group that's a bit more restrictive with the new threshold less than or equal to 4. And so in 2018, you can see both groups for both procedures were roughly about 6 in 10 patients. So a little bit more than 60%. And with the work that you've done, the organization has done, you see in 2019, the rates for prescribing less than 10 pills jumping up there to meet that goal of the 70%, with 70% with both EVARs and CEAs receiving at least less than or equal to 10 opioid pills. Rates for less than or equal to 4 around that time stayed about the same, just hovered just a little bit lower. And in 2020, you see another great jump with the higher proportion of patients getting less than or equal to 10 opioid pills. And then finally, some data in 2021 that show getting to about 90% of the threshold, 90% of patients getting less than or equal to 10 pills. So some really great growth there for both EVARs and CEAs. The under 4 pill group looks to have stayed pretty constant, about that 60% time there. So part of this is some of the rationale that's driving shifting of the measure. Once you get to about 90% of all the patients achieving a metric, I'd say, it's a great time to check the box, pat yourself on the back and say good job, and set your sights on another metric here. And so with the stable rates of under 4, but the majority of patients being able to recover with under 4, it's a reasonable next step to look at that. This just reiterates that about 60% of those EVARs and CEAs were prescribed for fewer pills. So again, a majority of people appear to be able to do that who are opioid naive, and that's providing that foundation for what we're talking about today. We'll shift and talk a moment about helping to teach patients to recover better. And so I break this up into 3 main points for some discussion, and then we'll point to some resources as well. And those 3 points are thinking through your process, helping to set expectations and normalize, and making sure it's really a team effort. And so I'll just briefly unpack each one of these. Thinking through your process, obviously an opioid prescription is typically happening as a result of the procedure afterwards. When you think through your process, really, I think, it's nice to kind of map out where the touch points with the patient are along the way, and where those interactions could happen with individuals within your organization that help inform them about both their what's going to happen in their care and what they should anticipate when it comes to their pain care and their opioid prescribing as well. I think much of our work in open in different healthcare settings, not necessarily related to BMC2, shows that individuals have a lot of their expectations shaped through their visits with their providers. Both physicians as well as non-physicians play really important roles in their interactions. That can happen through telephone-based methods with phone calls, clinic visits, and then also in the recovery area afterwards as well. But typically, if we're only focusing on the recovery area, we might be missing some of the boat, especially based on individuals who have conversations in the doctor's office or at other point in time. So it's something to consider as you think about what the process is like for the providers that you're working with in your organization. Setting expectations and normalizing what use is can involve sharing, some of this data that, okay, the majority of people only need 4 pills. There are other options for your pain control. These medicines are to be used, after you've taken other types of medicines for pain, and helping them to expect that that 4 pill number is typical and usual, is part of that process. Again, helping patients to anticipate so that at the end of the day, they're not surprised necessarily when they get a prescription for 4 pills and may have thought that more would be needed, when some of the data shows us that isn't the case for most patients. When it comes to the team effort, I think the emphasis here really is to, I mentioned about how the physician and non-physician providers can really leave marks on patients in terms of their perspectives about pain management. We've seen examples both within the state of Michigan, but also at other institutions where certain individuals have helped to set differing pain expectations for patients. These can be range from actual care providers to individuals who support them, such as medical associates, surgical technicians, others who can make offhanded comments about individuals' pain or pain needs. And so helping to align some of the organization's staff to make sure everyone's on the same page when it comes to what the metric is, what's driving the metric, that it can be done, that it's appropriate, is helpful to avoid some of the perhaps offhanded comments that may come through and distort expectations, where a front desk member may say, oh, I heard those are really painful procedures, or in the recovery area where individuals who may not fully appreciate what's happening say, oh, why'd they only prescribe that many pills versus you're going to need a lot more. So those are opportunities, I think, to engage across the spectrum of the care these individuals receive, to help do that. Part of our resources that we provide on our website are some of these handouts that I'm referencing here that can be used in different areas. Now note that these handouts are meant to be customizable to your organization. There's a link on the Michigan Open website that will allow individuals to submit for these brochures and handouts to be tailored to with the logos of your organization. And so they can be quite unique to your needs and make sure that they reflect the care that you're going to give there. It's a resource that we provide through grants from the state. And while our organization is based at the University of Michigan, we certainly do see our responsibility to help improve the care across the state and partner with organizations just like the ones that you're working with. So know that those are options for you. And then there are other materials and resources on the website that are available for you to look at. But certainly wanted to highlight some of those in the discussions and ways to help move forward when it comes to discussions about the new goals for 2022. So happy to chat some more and answer any questions that would be helpful.
Thank you, Dr. Bicket, for providing the details on, okay, here's our P4P goal, now what? And I did think it was helpful to mention that bringing in the PACU staff and maybe the people in the office who will talk to the patient on the phone, bring them into the conversation and maybe give them a script, so that they can talk, know what to tell the patient. That's good. So does anyone have any questions on taking care of patients, opioid naive patients after EVAR or carotid endart using 4 opioid pills or less? So from what I understand, the 4 opioid pills would basically be given, the patient would take them in the hospital maybe the next day, and then they would transition probably to Motrin or Tylenol. Is that usually the method of care for the 4 opioid pills?
Yeah, that's a great question. Some of the resources that we have provide a little bit more context. Generally speaking, if we're thinking that someone has pain that's sufficient enough to merit using an opioid tablet, then it's preferred that they're already taking around the clock doses of non-opioid pain medication. So for example, acetaminophen or Tylenol would be one example. If someone doesn't have any liver issues, that they could take between 3 to 4 grams of that a day. Now, extra strength Tylenol usually comes in 650 milligram tablets. It can be prescribed in 1 gram tablets by a clinician as well, and pharmacies can fill that. It's also an inexpensively available over-the-counter medication. And I think what we find is that patients just need a little bit of education when it comes to understanding the role that acetaminophen plays in alleviating pain. And then if other medicines are needed after that, then they actually help the opioids to work a little bit better. The other type of non-opioid medication that we typically recommend is a non-steroidal anti-inflammatory drug, or an NSAID, and ibuprofen would be one of those. Now, we certainly want to be mindful of individuals who have cardiac issues or have reasons that NSAIDs might not be the best choice for them. So if someone's had heart surgery before, sometimes that's not always an option. That being said, in individuals who can take that medication, you might be surprised to learn that they've compared how well a combination of Tylenol and ibuprofen can relieve pain compared to a prescription opioid. And it turns out that most patients actually report better pain relief when they take both of those together versus only taking an opioid. So I think those are some of the helpful tips that we often recommend for individuals to try. And we've certainly worked with organizations about changing their discharge order sets or other approaches to pain management to help both normalize the use of non-opioid medications and then make sure the right number of opioid pills are prescribed.
Well, thank you. So our sites can bring in Michigan Open, like when they're trying to help with the transition of prescribing 4 pills or less after EVAR and NDARTs.
Great. The audio was coming through, and I apologize if I'm breaking up a little bit. I think I caught some of that. It was about helping with some of the rollout at the sites.
Yes.
Yeah, so certainly our educational materials are available, and then I know through the collaborative, I would certainly encourage the groups. If there are specific needs that are coming up or questions, I think our organization wants to be a resource to the quality collaborative and the organizations there to help with achieving those goals. And there are ways where whether it's modifications to order sets or providing with discharge and materials or education that we can help inform some of those decisions that are getting made, and at least set in the right direction about how those things go. So certainly, whether it's coming through you, Rebecca, or others within the collaborative, we certainly want to be a resource here for you.
Yep. Thank you very much. Erica has a question. Her question is, would a patient having both an EVAR and carotid NDART during the same admit have any impact on the 4-pill recommendation? So do you think they would need more than 4 pills if they had an EVAR and they were opioid naive?
That's a great question, Erica.
Or what does the literature show?
Yeah, so we get into a little bit of a gray zone there. Just thinking about the sites and the pain recovery profiles, I would typically anticipate if both are being done, the patient's having a big day, but if both are being done and at discharge or when the patient's heading home, that the pain recovery profiles for both of these procedures are going to be similar, such that the 4 pills would still likely be okay in an opioid naive patient. A couple caveats go into there that, if they're done on the same day and then the patient's heading home, 4 pills would likely be sufficient to cover that, assuming they can take some of these other non-opioid medications. That being said, we certainly don't see that a lot. And I think it may be a question for the quality collaborative, if you're having somebody who's having them done on the same day, or is that the person who's really meeting the criteria for individuals who qualify for kind of one procedure versus the other? Because it seems to be a little unique. I just may not be aware of how often those are happening at the same time. So good question.
It is a unique situation. We have in our P4P measure, carotid NDARTs that are done concurrently with CABG, which is common. They would be excluded from the P4P goal. And then for our EVAR goal, it's the EVAR performed concurrently with another procedure. And usually that's an EVAR and open bypass, not a carotid NDART.
Okay. Helpful to know. All right. I think there's one other question there from Angela. Are there non-pharmacological recommendations? That's a great question, Angela. Yes, there are. And some of the materials on our website outline some different approaches to non-pharmacologic approaches to handle pain. Those can include different experiences from doing deep breathing techniques to mindfulness-based approaches. There's an element in there about the role of music and about ways to think about distraction. I say these 4 different areas, they're certainly a little bit more nuanced than just saying, go listen to music. But that being said, one of the handouts specifically deals with non-pharmacologic treatments and would be a good resource, I think, to at least have those conversations with patients who may not want to go to pills as the first option as they're coming through their care.